Hi, everyone. This is Lynn Crawford from Hope Dementia Support, and I am honored to have some of our community experts in end-of-life care. I'm going to remind you that if you have questions after they've had an opportunity to introduce themselves, if you'd put your questions in the chat or in the Q&A, and we'll make sure all of your questions get answered. So having said that, I'm going to start with Mary Buckland, because Buckland starts with B, and you each can, if you would please introduce yourselves and speak a little bit about the organizations that you work for. And I'm just going to disappear.
Hello, thank you. My name is Mary Buckland. I'm a nurse practitioner here at in Vancouver, Washington. I work at Legacy Salmon Creek Hospital in the inpatient palliative care world. And then I also have a private practice, Mobile Healthcare Providers Northwest, where I provide on-site services to seniors and a lot of memory care patients that have different types of dementia and offer a lot of primary palliative care. And I'm going to mute and let Dr. Tang go.
Hi, I'm Lynda Tang. I work at Vancouver Clinic at the 87th location, which is across from PeaceHealth Southwest. I'm 100% outpatient clinic, and I see referrals from families, practitioners for patients who have either early dementia or advanced dementia. And we do goals of care, we do some symptom management, we do advanced care planning, but a lot of it is expectant management over time. And it is a lot, I'm finding that our specialty and our support is so much more for the family and the caregivers than it is directly for the patient. And so there's a lot of care coordination and just a lot of navigating. So happy to be here. I'll pass this on to Michael.
Good evening. My name is Michael Colburn. I am a palliative care and hospice community liaison. So part of my job function, for PeaceHealth system. So part of my function really is to spread the good word of sorts about palliative care and hospice, and try to clarify the difference between the two entities. Really, my job is a lot of education, and then once that's done, really then connecting people to our hospice or palliative care agency or services, depending upon what the need is. And I will pass the baton to William Fogleman.
Good evening, I'm William Fogleman. I work with Community Home Health and Hospice. We're a local not-for-profit hospice, home health, and hospice facility center located in Salmon Creek. I am also a community liaison, and I do work with patients and families and hospitals, again, providing education to the community about hospice services. And also really what I focus on doing is working with families to kind of help direct what type of care they're looking to get, and where hospice, home health, or our hospice care center could kind of fit in with their long-term care plans and goals. And so that's really what I do throughout the community, and helping the community out with this service that we provide.
Perfect. Well, we were fortunate enough that one of our attendees actually sent us some questions ahead of time. So talk about forward thinking, and they're perfect questions to ask. So the very first one, of course, is what is the difference between palliative care and hospice care? And anyone can speak up. Or everyone.
I'll go ahead and start. So palliative care, we can follow people throughout the lifespan. If they're acutely ill or going through some kind of acute illness, disease process. Sometimes we follow people when they're going through cancer treatment, and we help manage symptoms and follow them alongside them with their oncologist. As Dr. Tang already touched on, we do a lot of goals of care discussions where we're really trying to define what's important to that person as they're going on their journey, whatever that might be for them. We also do advanced care planning. Who do you want to be your voice if you don't have a voice? Have you completed an advanced directive? Talking about end of life, also a lot of end of life discussions and what's important to that person at the end of their life. And then hospice is more when we are getting to the end of someone's life. Typically we are looking at if somebody if we think their life expectancy is less than 6 months, if their disease is progressing at a rate that we wouldn't be surprised if they were to die in 6 months, that is the time that we are really questioning, is it time for us to be having that hospice talk? And hopefully, if they've had palliative care involved, they've already had some of those conversations in preparation for that. If they are one of those individuals that has a disease that's been monitored for a period of time. And I'll let somebody else add their take on that.
I actually have an animation slide that I'm happy to share that host and disabled participant screen sharing. So if somebody will enable me to screen share. Okay, there we go.
Should be able, yeah.
There we go. Okay. So I animated it for you so you could see it.
Cool.
So to reiterate and to show you in pictures what Mary Buckland was talking about, she mentioned the words continuum. So I think of a person's life through time as a continuum. You can also think of it as a disease progression over that continuum. And a good way to think about palliative medicine versus hospice is to divide it into this continuum of diagnose, treat, and cure versus end stage and end of life transition. I think of life and palliative medicine versus hospice as kind of a very long hallway of time. And I think of thinking of your care team as your primary care person, your specialty care, your urgent care access, ER, hospital. And then I think of hospice as a different team, a team that is on the other side of the door of this long hallway. And what we're looking for is patients with chronic illness, as Mary said. So in this forum, dementia is termed a chronic illness, but it could also be terminal illnesses such as end-stage kidney or cancer. And what goes with those diseases is symptom burden. So for our dementia patients, it could be insomnia, agitation, anxiety, weight loss, appetite loss. It could be agitation or delirium, acute versus chronic. It could be hallucinations. So we deal with a lot of the symptom support of these chronic diseases. And if it's not dementia, let's say they also have COPD or they have heart failure, then you're going to have shortness of breath. You're going to have fatigue. So some of our patients want appetite stimulants or they want a boost of energy, for example. We can prescribe some medications that will enhance the quality of that life and symptom mitigate, but it doesn't reverse the trajectory of that chronic illness. And then, as Mary said, there's a lot of goals of care discussion. So there's the life burden aspect, there's the caregiver burden, the family burden, as well as what the patient's experiencing. So sometimes goals of care is, do we need to go to memory care? Do we need more caregiving? Do we need to go to a higher level of care? And our services at Vancouver Clinic, we have a nurse case manager. The hospital has social workers, chaplains, and whatnot. And so we can talk and navigate about readmissions. We can talk about what is quality of life, how many more readmissions are we going to have for pneumonia or sepsis or whatever it is that ails the person. So kind of just navigating what you want done, also saying what you don't want done. So DNR forms, for example, or tube feedings. So that's how palliative medicine takes care of those aspects. And then as time goes on, there's going to be a transition where the patients who have dementia are going to want comfort focused care. And so that's where hospice comes in, and that's where the less than 6 months comes in. So I've created this hopefully to let you visually see how that plays out. And if my other colleagues have things to add to this slide, I'd love to change or edit this slide, but this is it. And you're welcome to take a picture of it.
It's a great slide. So William, anything to add to this particular question?
So moving into that hospice focus of care from that palliative medicine focus, when we move into that 6 months or less diagnoses, or as the disease process kind of is running its course to a 6 months or less prognosis, that's really when that symptom management, or those hospital readmissions that you're discussing start to kind of become more reoccurring. Hospital admissions mostly based on symptoms that are starting to happen, not necessarily just the diagnosis itself, but multiple symptoms and managed symptoms that can be done in a home care setting, like pneumonia, infection control, things of that sort that can really be managed at home through a hospice focus of care to help palliate your patients in that home care setting. So if your end of life wishes are to be at home with your family, we can help with managing those symptoms and managing that care and keeping family members at home where they would like to, spend the rest of their time until, that end of life transition happens. So really working with that palliative medicine where you do have that aggressive treatments, like Dr. Tang had specified, when it's time for more of a focus for your goals to be at home, and instead of spending your time going to those doctor's visits, those hospital visits, the ER contact, when you're really ready to focus on family as a whole at home, managing symptoms and taking care of those goals through that short-term timeline that you have left, that's where hospice can step in and really help with social work, with chaplains, with helping direct if more caregiving is needed and how we need to get those goals met for the family. So again, you don't get caregiver burnout, but you really have a team focused to help palliate your family member at home, help your family as a whole to really be able to spend quality time with your family together as that end of life transition process happens.
And then
Excellent.
one thing
Thank you.
I'm sorry. And one thing I'd like to add to that is when someone's on palliative care, there is still treatment going on. This is one thing I always want to make clear to everybody is that there is still treatment. You're still seeking some kind of resolution to the illness. But once, for whatever reason, you've reached that point where you do not want to continue going to the hospital, you don't want to go to the doctor's office, the treatments aren't working anymore, and you just want that quality of life. And that's when you start thinking about transitioning to hospice. And then on hospice, the treatments do stop. So there are some palliative things that occur, of course, for comfort. But as far as, like chemotherapy, that might be an example. If somebody has cancer and they're ready for hospice, the chemotherapy typically stops. So I just want to make sure that people understand that once you transition to hospice, the treatments will end.
Thank you. What are the major signs?
And Carrie Riley's
Where that came from? I am echoing. I don't know why.
Mary, it looks like you have two. Okay, there. I think that fixed it.
Is that it? Oh, that was what it was. Got it. So we have a question that says, what are the major signs that says a person with dementia is ready to seek either palliative care or hospice?
I almost feel like I have to answer that question, but of course anybody can chime in. Typically the patients that get referred to me are family needs care coordination. Dr. Tang, it's harder to take care of my dad, my mom, my wife, my husband. The symptom burden is getting higher. We just need more care. So then it could be a transition of, I need a higher level of care. I need memory care level. I need SNF level or skilled nursing facility level, or I need private caregiving in the house, or I need some sort of paid caregiving or a county funded health, home health caregiving, such as light duties in the house, making meals, do some light housekeeping. So that often gets into my lane, and there's like, we need more help. So it's more resource based. Sometimes it's the neurologist or the ER doc or the hospitalist or even Mary. She's like, hey, you really need to, come and talk to palliative medicine to kind of straighten out your goals. Like, what is quality of life? I've noticed that your mom has been in the hospital 7 times for recurrent pneumonia because she's not eating well and she's having trouble swallowing. And so pneumonia once or twice a year probably won't drag you down, but pneumonia 7 times a year will take so much away from an advanced age person that also has dementia. So when goals aren't very clear, our family's really struggling about what do I do next? So I think of it like a road trip. Do I turn left? Do I turn right? Do I go straight? Where's the map? We don't have a map. Then you should get connected to somebody who can draw that map, help you color it in, and design it so that it makes sense to your family. It makes sense to your quality of life. It's not a map that I draw for myself. It's a map that I help you draw. So then you kind of know where the detours are. You're not going to make decisions in haste. You're not going to wait till the chaotic moment happens and then you scramble to get your affairs in order. So those are some of the common reasons that people come in. A third pocket is, I remember having a really loving, connected set of daughters that, and we're talking like they take their mom out to lunch like once a week. They wear pearls and they tee it up. And as their journey was with me over a couple of years, which I was privileged to be a part of, the window of cognitive started to close on mom. And so they were like, wow, I wish we could rewind a year back and ask mom how she feels about feeding tubes and dialysis and transplant, or, even antibiotics for recurrent UTIs. Because at that time, mom was still alive, but her cognition was going. And so they're like, we don't really know how she feels about these things. And they're like, if only we had asked her a year ago, we would, as sisters, feel more comforted in being her power of attorney so that we could really serve her goals and really serve her quality of life. And so that was kind of a lesson to say that if we could help guide that map in advance before the cognition goes away. So sometimes you're not waiting until it's very dire to come talk to palliative care, but it's like, can we talk to a specialist that will help navigate goals of care and just trajectory and anticipatory guidance? That seems to be helpful. And quite honestly, if I see you upstream, I might just see you once a year. I might see you twice a year. And then as things get more complicated, then I might see you every 3 months. And I think it's appropriate to be plugged in advance. And then I'll let William or Michael or even Mary talk about when you should go to hospice, because there is a scale that you want to kind of check off in terms of going to hospice.
So I know that there are some very specific guidelines from the federal government related to dementia diagnosis and hospice being eligible for hospice. Could you guys speak to that a little bit? Michael and William, who are the folks that tell people this all the time. This is your test.
Definitely. So dementia is a little bit difficult at times to qualify for hospice services. A lot of times with our dementia patients, dementia isn't the primary diagnosis that's utilized to put them onto hospice care. There's usually some underlying conditions that we can work with, that Medicare guidelines have for us to be able to qualify a patient into hospice care. Not saying that dementia can't be utilized, because it can. It just really is depending on how far along you are with your dementia or Alzheimer's diagnosis and what that patient is able to do independently or with their ADLs, memory-wise as well. And it's usually about, I think, 3 to 4 words that they can speak before we can actually get a dementia diagnosis as a hospice diagnosis. But again, there's usually underlying conditions that we can work with to really help guide the family into the focus of care that they need. When we're working with dementia patients, Alzheimer's patients, a lot of times it's a good meeting to contact hospice and have those discussions. I do push, my agenda out in the community is hospice sooner than later. You can always reach out to hospice to be evaluated and help guide and plan out those goals of care for you. That's what us here as liaisons are here to do, is to really work with you as a family, evaluate, your family member and see where they are with their dementia diagnosis, what underlying conditions they have, and at what point in time is hospice going to be a good fit for you to move into, because we're seeing that decline with dementia, with Alzheimer's, their underlying conditions to that 6 months or less prognosis. Now, those are state guidelines that we have to follow. Doesn't necessarily mean that a patient's going to pass in 6 months, because we can't make that determination. We can only evaluate and based on what's been going on, see where that patient's at. But you don't need to have doctor's orders or palliative order to be evaluated for hospice. You can always just contact us at Community, PeaceHealth, whomever you want to work with for hospice care. And we can go out there and kind of help guide you through, what process is going to work best for your family at that time, and when you're ready to move into a hospice focus of care, a palliative focus of care, or continuation with home health aggressive treatments until we need to move into those other focuses of end of life care.
What I would also add to that is, just real quick, my background, I've been a part of hospice for the last year. And so I was actually in the hospital doing community liaison within the hospital. I learned a ton of stuff in that time. One of the things that I saw is, and what I always caution people to avoid in this scenario, is really waiting until the last minute to use hospice, waiting until the last minute to involve palliative care, because what happens is a lot of times hospice is that scenario of breaking the glass and using the hose all of a sudden, in the sense that it's like, oh, mom is dying. And then you have 2 or 3 siblings that may not have been close in the past. And so mom, who has dementia, really can't speak for themselves anymore. And then the siblings want to get involved, and had, POA paperwork been done in advance, had these discussions, goals of care had taken place in advance with palliative care, or hospice started earlier when the family member still had the ability to communicate. It would have made the whole process so much easier. So just really in short, what I'm trying to say is I'm advocating for utilizing palliative care earlier. There's, a lot of people will ask, is there a cost? And there's not a cost for, well, the insurance covers palliative care. The insurance covers hospice. And so don't let that be a detriment, and, take the opportunity to explore these services as opposed to waiting until the last minute. Because when somebody's on hospice, they don't have to die. I mean, they don't have, we've talked about a 6-month period of time, and it is a guesstimation, but if the hospice nurse can document that, that there are changes and the patient is declining, they can still be on hospice after 6 months, or the patient has the right to revoke or cancel hospice. And it's like, no, I changed my mind. I want to seek treatment again. It's not, when a doctor or provider feels that someone, whether it be you or your loved one, qualifies for hospice, again, there is an estimation that that person will pass away in 6 months, but they don't have to. And it's the one other thing I've learned about hospice is its flexibility. It really is a very flexible service, as well as palliative care. So just don't wait. My recommendation is don't wait until the last moment. Start seeking these things out before it becomes a real burden to deal with in the last waning days of your loved one's life.
I will show another slide if Mary wants to continue talking, but I do want to show the slide so that you guys can see, you folks can see the criteria. It's like a continuum of dementia, and then the black and white criteria is stage 7C. But as we had mentioned, it's not a hard and fast rule. If you're showing rapid decline, you can get into hospice, and then we'll conditionally kind of see how it goes for a month on a trial basis. Most of the time, people aren't dying from dementia. They're dying because some opportunistic thing gloms onto dementia's frailty and causes people to go over that cliff. So it could be pneumonia, it could be COVID, it could be CHF, it could be sepsis, it could be dehydration and electrolyte abnormalities. But the dementia kind of sets up this frail vulnerability that then tips people over.
So, Mary, is there something through your experience with your dementia patients that we've missed in this conversation?
Thing that I would like to just offer up, because what I found is a lot of people don't know this, so forgive me if it's redundant for those that already know that. Dementia is a blanket term, umbrella term for varying types of damage of the brain. There's Alzheimer's dementia, which is the most common. You can have vascular dementia from strokes. You can have dementia from alcohol abuse, frontotemporal dementia. So I just wanted to offer that because a lot of people don't realize that there are several different types of dementia. And it looks like what Dr. Tang has shared here is the FAST score, which is what is typically utilized for us scoring Alzheimer's patients to see if they would, if they qualify for hospice or not, and we gauge where they are. Some other types of dementia, dementia related from Parkinson's. There are other symptoms that we look for. And so many times what Dr. Tang said is true. So many times we are seeing not necessarily the dementia itself causing the decline more, or causing abrupt changes rapidly. It's the opportunistic infections that come into play, the pneumonias or falls, sometimes just behaviors. Sometimes we can't get behaviors controlled in spite of the pharmaceuticals that we try to utilize. If we have somebody that has prolonged behaviors and we can't, excuse me, we can't get them to respond to medications, that in itself can be a terminal type of event for people. So there's a lot of things that we look at depending at the type of dementia that we are dealing with. So forgive me if that was redundant for people, but I have learned over the years that a lot of people don't realize that. So I always want to put that out there.
Thank you. I think that your FAST scale will be helpful, Dr. Tang, with a couple of questions we have here. And one is that my mother has late stage frontal temporal dementia. How will I know when she is transitioning to end stage?
Yeah, I'll show the FAST scale again. It'll help you to see that this is the continuum. So it gives you a little bit of anticipatory guidance in terms of this is what I would call probably more mild cognitive decline. I mean, I forget objects right now, but I don't have work difficulties, thank goodness. And then you get to level 3 and then 4, and you can just see the severity starting to kind of go, it becomes more apparent. And then when you really get into this level 7 is when you're like, okay, things are kind of happening. What actually happens more often in my office is the family will come and they will say, she's just not eating. She's sleeping more. She's more symptomatic. She's losing weight. We just came back from the hospital where she had a mini stroke or she had pneumonia, and we were there for 7 to 10 days because she just couldn't recover, but she made it out. We're now in rehab and she's coming home. And it's kind of like, if that were to happen again, I really seriously would wonder if she's going to make it out again. So this is where Mary's team comes in. I never want to realize that some of my patients die in the hospital, unless the ones that say, I would like to die in the hospital. It's very, very few. Most people are just like, I want to die at home. I just don't want to be hooked up to tubes. So if I get the sense that it's going to happen again, and that there's a less likely chance you're going to survive and walk out of this hospital, then that's when I tell the family, I'm like, look, you see your mom, your dad every day. If you notice a drastic decline from the last 3 months, then that predicts that that decline is going to continue. So I'm going to answer that question. Let me get you another slide because I have so many great slides to show you. I will show you that trajectory, and then I can speak to a little bit more of it. But the idea is history repeats itself, and what happened 3 months ago is going to happen in the next 3 to 6 months. So I'm going to pause there so I can get you the picture that I'm talking about, and then I'm going to open up to my other colleagues to fill up some time while I get this slide ready.
Well, another question. Can you talk about the approaches to palliative care for people who are mentally ill or for people who have been longstanding alcoholics who have developed dementia?
That's a tough one. You certainly when we are trying to have goals of care and conversations about end of life to those that have mental illness, it is really important that we still understand not only their disease process. As a clinician, we want to understand the disease process, but it's also very important that we still respect that person's preferences. You know, what is important to them? What is their understanding of their what's going on with their body and their disease process? and depending on how not only their mental health or illnesses are affecting them, can also impact how we approach trying to support this person as we're navigating a disease process with them. Excuse me. Sometimes if you would use the example of alcoholism or alcoholic dementia. If we can do tests to determine if somebody has cognitive deficits and really may not be able to fully grasp or understand or retain the context of the conversation or what is being presented to them. And it's really important if we have somebody that we have tested them and maybe they have deficits in their ability to comprehend and literally wrap their mind around concepts, then sometimes in those scenarios, that's when we need somebody else to help be a part of the decision-making process for that person, whether it be a court-appointed guardian or a power of attorney. If they've been somebody that said, if something happens and I lose my voice, I want my brother to be my DPOA. If not, then it can take a little bit longer to get the right people in place to make sure you're supporting that person. But even if we have somebody that does have deficits, like your example of alcoholic dementia, it's still really important that we remember and keep in consideration what that person's preferences are. Or what they were before the disease set in, because that still should be a part of making decisions for that person moving forward, even if they fully can't comprehend what is being presented to them. Do you got your slide ready, Lynda?
Yeah, you're muted.
It's not the best one, but it'll be a good enough one for now. All right. Can I already see that? So what you're looking at here is a map. This quadrant down here is dementia. It kind of undulates. It's very slow. So that's why we say no one dies of dementia outright directly. This graph right here is more like cancer. You're doing fine. Your function is high, but then once you stop treatment, it just goes down really, really fast. This is more Mount St. Helens erupting and then we just die. This one right here is what I was talking about in terms of a projection. So if you have chronic illness on top of this dementia, so it's this graph overlapping with this graph. But in organ failure, you're talking about your COPD, CHF, even pneumonia. You're looking at where function is originally high. Then you get hospitalized and you lose some function. Then you go to rehab and then you gain some function. Then you exist for a little bit, but then you go back to the hospital, you do some rehab, and it just keeps on happening over and over again. So what I usually ask people in my consultations is, 12 months ago, where was mom? And they'll say from 0 to 100, mom was, let's say 80%. Then I'm going to say, all right, today, right now, 12 months later, which is today, where do you think your mom is? And they'll say, oh, 40%. So I'll draw this graph and I'll say from 80 to 40 is a 40% drop. If you drop another 40% in the next year, you're down to 0. So the best case scenario is you stay at the 40%. It is your new 100%. And that's where you're going to stay if nothing happens. If you go and get into a car accident, then that 40% goes to 0 in a matter of that moment. So somewhere between the 40% staying the same and the 0% happening because of a car accident is where your mom's going to be in the next 1 year. So if the decline and the slope of the decline is rapid, then the next couple of months and 1 year will be rapid. If the decline is just kind of slowly changing, it's been 10% loss, then you're probably in the clear. So you have to kind of look at your own crystal ball in order to predict your future. If the last 3 months have been really chaotic, lots of loss, came home from the hospital, haven't really recovered from the hospitalization, then you know you're at a new normal. And then you might be at risk for another rehospitalization. But if life has been kind of boring and you're just kind of hanging out, then you're probably going to be in the clear without an act of God or lightning striking or a car accident. So that's been the best prognostic crystal ball I could give you. Cancer, which is right here, it's relatively easy for me to say, okay, you got this type of cancer, you got about a 2-year prognosis. But when it comes to COPD, dementia, we're really looking at you specifically as the crystal ball. What has happened to you will predict what is going to happen to you, because history has a way of repeating itself.
This is my question. I'm not sleeping here. What can families expect from hospice and palliative care? How will it be helpful to the family, to the care partners? I would look at our liaisons to answer those questions.
From a palliative care and I guess hospice standpoint, we understand and are very aware that, part of this whole process, it includes the family, and that's what the services are there for, is to support them, to support the caregivers, right? Because frequently the family members are the caregivers, and they are tireless in, especially when your loved one has dementia, and you just don't get a break if you're taking everything on upon yourself. So to answer that question, again, both teams, palliative care is going to consist of the doctor, of a nurse, of a social worker, and spiritual care, and then also the patient's doctor, and they team up. And part of what they do is to work with the family on what kind of support they need. There are community resources out there that people aren't aware of. So social workers, the Hope, is a perfect example of one of those community resources in getting people connected with the appropriate service, because they need a break and they need support. And then along with hospice, you get, again, the doctor and the nurse, a bath aid. And again, these are all things that the hospice benefit covers, a social worker, spiritual care, and all of these services are not only there to support the patient, but they check in on the family. Oh, and bereavement. I forgot about bereavement. So there are people to talk to once the family member who has the terminal illness finally does pass away. There are folks available to grieve, to talk to. I know the hospice benefit covers bereavement up to 12 to 14 months after somebody passes away, because people grieve differently and at different times and in different ways. And so, if somebody, the family member, let's say, passes away today, 3 months from now, 4 months from now, that's when the caregivers could actually start to grieve. And so to have that available for them, again, somebody to talk to, because we all deal with grief differently. So there are a multitude of ways of the services can support the caregivers, and a lot of it is just giving direction, where to go and who to contact.
Also adding on to that, with hospice services, a lot of what we can do as far as support goes is when you have hospice coming in the home, like Michael said, you have a care team that comes to you as a family as a whole to provide care for your family member. Now, it's not 24/7 in-home care. We are a supplemental care service, so we're not going to have caregivers with hospice in your home taking care of your family member all the time. But we do have social workers that can help direct you where you need to go to get those types of services and those types of care. When you call on hospice services, we do have 24/7 on-call support for you. So if there's anything happening with your family member, if there's any issue, if you have a simple question, if you're worried, you call, we answer with the RN, and we respond appropriately, whether we need to send an on-call nurse out there to see what's going on, help direct you over the phone to let you know what medications to utilize to help with any symptoms that are starting to come about, so we can help support you in that sense. We also provide volunteer programs, volunteers that can come and help out around the house, spend time with your loved one, so those caregivers can have a little bit of time, a little bit of a break for themselves to, again, try and help with that caregiver burnout. We have respite services that we can provide care at our hospice house here in Salmon Creek. A family member can come and do a 5-day stay with us, give you all time as a family to step back, rest, recuperate, and then be ready for your family member to come back. Or if they're reaching more of an end of life care needs, more of a general inpatient, high symptomatic care that needs to be done, then we can move them into our hospice house. They can stay with us until that end of life time comes. Our hospice house was designed for short-term stays. It's not a long-term care facility for dementia support. It's more of end of life care for when your family member is getting to that point in time where we're looking at a week or less that they're going to pass. And then we can move them in there and take care of them and support you as a family in the facility to have that care, as well as the bereavement support, is there as well for the family members long-term and after that happens, as well as pre-bereavement services. So, we're really here as hospice to help the family cope and understand with the disease process and what's happening. Like Dr. Tang was speaking about earlier, when you see your family member not eating, resting, sleeping more, the body could be going through a transitional process where it's slowly beginning to shut down and it doesn't need as much food anymore. It's not as active anymore. You're not having bowel movements as often anymore because the intake is lower, because they just don't need that much intake. They don't need that much food because their body isn't able to process it, because it's more work for the body to process a large meal than those small meals, because it's slowly starting to shut down. And we help you as a family understand those transitional points, and we help to guide you through that transition as well. And so we're really here, and that's how hospice can really help, is just not only educating the family, supporting the patient with medications, with needs, and just making sure all around that if you have questions, if you're not understanding something, if there's something more that needs to be done or something less, that's what we're here to do, is to work with families and get those goals, those long-term care goals that you have to plan out, those care goals that you as a family need to sit down and really focus on what you realistically expect to happen over the course of this disease process. And us as liaisons, as doctors, as palliative medicine, really can help direct and map that out for you and give you different opportunities or different resources to utilize. That's what we're here to do, is really just help you as a family figure out what the next step is, whether it's hospice, home health, palliative care, aggressive treatments, whatever you as a family need to get you to the point of being comfortable when end of life is called.
You mentioned it briefly, but could you talk about eligibility one more time? I know that I have had people in our groups say, well, we talked about it, but they said that they're not eligible for hospice. They're not ready for hospice. Can you kind of clarify that a little bit?
Definitely. When we go into an eligibility, it's always based on the patient. There's no real specific guidelines other than what Medicare does provide for us. So it's not hospice saying, you know, you don't qualify for hospice because that's what we see. No, it's what Medicare guidelines kind of have set for a patient who is at end of life care and who is making that transition. So when we're looking at eligibility for a patient, especially with a dementia diagnosis, that FAST list is kind of what we go off when we're looking at dementia. Now, if we get close to, you know, those 6 words or less, incontinence, no longer independent, not able to stand or ambulate on their own, you know, those are signs that we're getting closer to end of life. Maybe, you know, we are needing to look at dementia as that eligibility diagnosis. But a lot of times, like with alcoholism, you know, you can develop dementia from different diagnoses. That's not going to be your primary diagnosis of dementia. We can move into, you know, a respiratory or liver functions, renal failure. There's lots of different things that can be going on with a family member when dementia is or Alzheimer's is present. So really what we need to look at is what your long-term goals are. Calling one of the liaisons, calling community home health and hospice, whichever hospice service you want to work with, contacting someone and saying, you know, I'd like to really learn more about what direction our family would like to go. We can gather medical records, we can review those medical records for that family member, and we can come up with a plan, a care plan that might work well for you and your family. And then take that to your physician if you want to talk to your physician about it and say, you know, this is kind of what we've been looking at. What's a good direction? What does your physician feel? And just kind of reviewing each person as an individual to figure out where they're at with their diagnoses as a whole. What can we make them eligible for with their transition, with their end of life, with their diagnosis, and just go from there and figure out what the best next course of action is really just laying out a good plan of what you as a family, what your goals are needing to be met, and where hospice falls in and at what time it falls in at.
So what can palliative care provide me that my PCP can't?
I'll answer that. So there are 2 differences. There is primary palliative care, which is palliative care that any practitioner can start. It could be filling out a post, durable power of attorney, goals of care, some symptom management. It depends on how facile that practitioner feels comfortable in doing primary palliative care. Specialty palliative care is palliative care at which someone went to fellowship, just like being a cardiologist. So the PCP can do some hypertension, some CHF, they can do a lot of some cardiology management. When it gets very complex, they refer to a cardiologist for more specialized, more harder cases. So when the care becomes very complex, such as the question in the chat in terms of getting family consensus, in terms of getting cognition, getting insight, matching it with judgment. When people are not withdrawing care in the ICU setting, they will call Mary Buckland, the specialist, to navigate the really tough cases. If you're having issues with nausea from the chemo, or you're having shortness of breath, and you really want heavy duty, specialty trained palliative care symptom management, your PCP may not feel comfortable giving you Ativan or giving you oxycodone or managing it, especially if you have kidney disease overlying all of that. So that steps into the space of specialty palliative medicine that the PCP, it's not that they can't do it, they don't feel comfortable doing it. So we're not the gatekeepers. Once a PCP or specialist doesn't feel comfortable doing something, they're going to ask for help. And that's when the referrals start coming to us to fill that gap or to be able to fill that need. Now, I've had referrals where the family says, I would like to see palliative care. So then the PCP or specialist will say, I think that's a great idea. Let me send you a referral. If it were left to them, they are the gatekeepers. They are the ones that pull the trigger and say, you know what, I'm not comfortable doing this. Let me send you a referral. And then I want a specialist eyes and opinion and expertise to do this. Fellowship training for specialty palliative care is about a year. For cardiology, I think it's about 3 years. For geriatrics, it's 1 year. For various different specialties, it varies how long the training is. And so that's the difference between primary versus specialty palliative medicine.
So if we make the determination that we would like to have palliative care, or that we would like to have our loved one placed on hospice, do we get to keep our PCP? Or is that relationship over?
So looking back at that continuum again, so I think I can speak well, but 1,000 words is better than just me. So let me share this again. The short answer is yes. The technical answer is it depends. So where am I? So looking at this continuum again, when you're on palliative medicine, just like my colleague said, you might be actively on dialysis, you might be on chemotherapy, you might even be waiting for a transplant. I have a patient that I've seen since 2015, 35 years old, on the transplant list for 2 organs. So if things go well, she's going to graduate and she's not going to be my patient. If things don't go well, you can see how she goes to hospice very quickly. So while you're on this end of the spectrum with palliative medicine, you're still seeing all these people, your primary care. I prefer that you still see your primary care. You'll still see cardiology, oncology, pulmonology, surgery. You're still using the hospital and the ER and the urgent care. It's only technically when you go over to hospice, that's why there's a door here. You can't be on both sides of the door. You have to choose one side. And only when your goals are comfort-based. So as my colleagues say, only when you decide, I'm done with chemo, or your doctor says the chemo is killing you faster than the cancer, then the cessation happens. So it's not us withdrawing support. It might be that your body can't handle it anymore, or that it is too tough on your system, or that the chemo or the treatment, the dialysis is just too hard on you. So I don't want you to mix up the idea that you're giving up or we're giving up. It's that the natural process of the body can't handle it anymore. And so you're reaching end stage. So when that happens and your focus is comfort, you get to go to hospice. You're eligible to go to hospice. But let's say you have a qualifying diagnosis, but your soul and your spirit and your family isn't in a focused comfort way. No one from hospice is going to come visit you. We need your permission in order to make a referral to hospice. So 2 things have to happen. Your goals have to align with hospice, and you have to be eligible with a diagnosis of less than 6 months. If one of those things happen and not the other, hospice doesn't happen.
So what kind of decisions would I have to make to determine I want palliative care or hospice? And would somebody help with that decision making?
So when you're moving into a hospice focus of care, it's really understanding that you're ready to be comfortable at home while your disease kind of goes through its transitional process to end of life. It's not giving up, but it's, again, like Dr. Tang said, understanding that, you know, where your disease process and where the treatments lie are either hurting you more than your actual disease process. And now it's time to just move into a focus of symptom management. So as your disease process runs its course and symptoms start to come about, that's where hospice kicks in to just really focus on managing those symptoms and not necessarily curing, the disease itself, or testing to see where the disease is, or where the disease is at. Sorry, that's kind of a mouthful to say, but we're really just focusing on the symptoms as they come about and understanding that the disease is going to run its course, and you have the support of hospice to manage those symptoms, help you as a family through that transitional period, help the patient through that transitional period, and understanding that we are your on-call, we're your emergency, we're your doctors. We are there to support through that end of life, and we as a hospice are not going to try to figure out what's going on as more as what's going on with the disease as it is managing the symptoms that come about as that process goes. So when you're moving into a hospice focus of care, you as a family, your decision maker, your power of attorney, whomever is making that decision has to be ready to say, I am ready to stop with the doctor visits. I'm ready to stop with the ER calls. I'm ready to stop with the poking, the prodding, the testing. All of that is going to stop. We are going to be here. We're going to be at home. We're going to manage the symptoms as they come about. We're going to care for each other. We're going to be here with each other until you transition.
To answer that question from a palliative care standpoint, you can initiate palliative care if there is a serious illness, a chronic disease. You can pursue palliative care at any point in that chronic or serious illness, and you can do that at any age as well. So if somebody has COPD, has a diagnosis of that, and they need support, as we have talked about before, from palliative care, they can talk to their provider and initiate or request a palliative care referral. So it can really start at any time once the diagnosis has been made. And then I saw a chat question. Sorry, it popped up on my screen about a PCP on when you're on hospice. We always ask the PCP if they want to participate, if they want to follow the patient once they're on hospice. And probably about 9 times out of 10, the PCP is willing to follow. So they remain the patient's doctor. Every now and then, though, sometimes the PCP does decline that and say, no, I don't want to do that for whatever reason. And then the hospice agencies each, they have their own hospice provider or providers that are willing to follow. So if the PCP is not willing to follow their patient while they're on hospice, while they're transitioning, then the hospice agency will have somebody who can fill that role.
I'll add that the focus changes when you're in comfort care or end of life. The focus is not to get another biopsy. The focus is not to get intubated and be on life support. The focus is I want to go to Hawaii, dye my hair purple, and die at home. That actually happened to one of my patients. The focus is not IV infusions. It's not to get a clinical trial, because if that focus is another clinical trial, you're not going to hospice. You're going to stay with palliative medicine. You're going to stay with oncology. You're going to roll the dice and go to the hospital, and Mary will see you. But if your goal is that I'm just done being prodded, I don't want to be a test subject, I don't see myself getting better, stop taking my blood, stop bothering me, then those needs aren't rooted on the side of palliative care and your specialist. The need is, I want a nurse to visit me on a weekly basis. I'd like to talk to a chaplain. I want to spend Thanksgiving not going to dialysis. I would like to be at home, and I want to think about putting meaning into my days and days into my life, instead of, just adding days for the sake of adding days. I really want quality, but not quantity. Because if you told me that in the last 6 months, I could be at home and not getting my blood drawn or being poked or going in and out of the hospital, but I had 6 months, I'd rather those 6 months be like that than 6 months where I am under treatment. Because if I'm gonna die, I don't want to die because I worked so hard being a patient. I want to die because I'm human. I want to just kind of be left alone. And granted, I'm biased. That's what I want for my life. But some people want to say, I want to go out with a bang. I want to do everything possible and leave no stone unturned. And I've had patients do that. They just want to light things on fire and go out with a bang. You have the right to do that. You don't have the right to ask for things that the medical community can't give you, but you have the right to defer anything that we offer you on the buffet table. That is within your right. But if you want a surgery and the doctors are saying that's too risky, they have the right to say, I won't operate on you. They have the right to say, I can't give you any more of this chemo because it's more detrimental to your health. So I want to make sure that we understand the balance and of the ethical rights as well as the legal rights. And then I think ethics is really what it is. There's no way I'm going to give you something that's going to kill you faster. And there's no way that I'm going to do something that is very, very risky. But if I offer you a third line drug or a fourth line drug, you have every right to say, no, thank you. I'd rather take my chances with just being at home, being with my family, going fishing one more time, going to the coast one more time. Whatever it is that makes sense to you, you have the right to defer.
So how is palliative care and even hospice addressed in the hospital setting? I know I have had the experience when people have been transitioned to hospice, but have been too ill to leave the hospital. So what happens?
So to clarify, Lynn, is it those folks that we've made comfort care, but they're not going to be able to go somewhere on hospice? Is that the question?
Yeah,
Okay.
does that happen?
Yes, it does. It happens quite a bit. Sometimes a disease will progress or an illness will progress at a rate that is faster than we can get things set up to get them either back home with hospice care or in a hospice house, or maybe there's no place for that person to go. Their care setting was much different and they don't have caregivers or they don't have the support to be able to go home on hospice. And a lot of times, palliative care is involved in those cases. We're talking to the family about, and the patient and the family about how we think things are progressing and talking about symptom management. And the term that we use when we are no longer doing all of the things that Dr. Tang described. We're not doing the poking and the prodding. We're not doing the tests. We're not doing the biopsies. You will hear the inpatient medical teams refer to that as comfort care, which means we are no longer focusing on numbers and monitors. We are focusing on that person and how their symptoms are presenting and how they are feeling, and making sure that they are as comfortable as possible for whatever time that they have left. And many times we have patients in our hospital. We have their family at the bedside. We try to make things as homey as we can for them, things that remind them of home, and we keep them comfortable as if they were a hospice patient out in the community, and we keep them comfortable until they die.
So have each of you got an example of a person who has had dementia and has had a successful transition to palliative care and hospice, that it's been good for that individual, not just for their family, but for that individual as well?
I've had several. I think one lady that I started my private practice 15 years ago, before I ever became board certified in palliative care, and was doing primary care, or I'm sorry, doing primary palliative care and primary care in a memory care unit. And I was fortunate enough to meet a lady that had come and saw me at a primary care clinic, and had found out that she had early onset Alzheimer's. She was 60 years old when she presented to the clinic, and she'd heard about me and wanted to ask me some questions about dementia, Alzheimer's type dementia. And I was blessed enough to be able to really have all the anticipatory guidance, the advanced care planning, the goals of care discussion, getting her durable power of attorney in place. All of this was prompted by this lovely, empowered woman who knew that the clock was ticking as far as time, as that she could really get everything laid out into place as far as what she wanted. And she went so far as to tell me about 2 years into, this was about 2 years into her disease process, how she wanted her death to look and what she wanted her death to look like and who she wanted to be present, and how, you know, how she was open to hospice. And she really not only empowered herself to advocate for herself, knowing what was coming down the road from her, but she really empowered me, and she advocated for me as her primary care provider to make sure that I knew what her wishes were, and to make sure that I was assuring what her comfort, what meant comfort for her to be comfortable, what she defined comfort as, what she defined dignity as, what she defined herself as. And I will tell you that was very early on in my journey of starting this type of work. And I have brought that forth with me since, you know, almost 15 years ago, meeting her. And it really, I think, helped instill in me the importance of really asking questions, asking those probing questions about what's important to a person when they get diagnoses. And it doesn't have to just be a cancer diagnosis. It can be a congestive heart failure diagnosis. It can be, Dr. Tang talked about people waiting for transplantation, you know, advanced kidney disease. There's just a myriad of things that can be considered and talked about early. And sometimes we don't like to step in the stuff, and you guys can fill in what I mean by stuff, but sometimes we don't like to step in it. But by stepping in it, we acknowledge it, we know it's there, we know it doesn't smell very good, but at least if we talk about it, then we can start working together to formulate a plan, even in the most unbecoming of circumstances sometimes.
I like that you said stepping in it. One of my favorite phrases in communication, but also in palliative medicine, is it's not about avoiding the stepping. It's that you will step in it, whether intentional or accidentally, you will step in it. But what we can do to help is that we will help you wipe it off so then you can keep walking, because the option to stand still is not there. There will be questions from the hospital. What do you want to do next? There's going to be questions from your family members, your siblings, anybody that has an opinion. I'm like, what are we doing next? So avoiding stepping in it is actually not likely to happen, but who can help you wipe it off so that you can keep going and have a roadmap? And that's where we come in and where we're good about doing that.
There's a question about what can palliative care or hospice offer to a dementia patient who is at a stage 6 or 7, but there are not currently any other conditions, just the dementia.
So as far as hospice goes, you know, when you're at that dementia stage, the best thing is to contact us and have a nurse come out and do an evaluation in home to kind of see where they are as a whole, because we'll want to take into account, you know, height, weight, you know, intake, you know, where's the decline been. Stage 6 or 7 is getting pretty close. There's a lot of things we can take into account, even though there may not be any underlying conditions, just to kind of see how your family member's doing all around, and seeing where we can step in as hospice, or if we need to move into palliative care, or if we need to move into a home health focus of care with physical therapies to kind of evaluate and see a steady decline, and that way we can gather more information to be able to move into a hospice focus of care if that's what your goals become. So it's always best just to contact hospice to come and evaluate a patient who's at that level to kind of see where we are at and how we can help at that point.
So I answered this question in the Q&A, and I'll expand upon it a little bit more. It depends on what's needed or what hasn't been done. So if you don't have a DNR form or a pulse form for resuscitation, we should talk about it. If you need to talk about goals of care, we need to talk about it. Maybe you have some conflicting family member opinions. We need to have a family meeting. We need to explore quality of life exploration. We need to explore sort of the what ifs. If there are symptoms of agitation, insomnia, anxiety, depression, constipation, nausea, whatever it is, we can help you with those symptom management, especially if things aren't heading south fast. Then you've got a long time until something tips over. The menu is actually very varied based on the assessment of that consultation. So there isn't a blanket answer. I would say that every consultation that I've had that was too early has taken up 60 minutes, and there's always something that hasn't been done. Sometimes it's just answering questions for the caregiver and the family as, what can I expect when this takes a turn? And it takes me looking through the chart and saying, coming all together, the greatest threat right now is probably the kidneys failing, and it's not going to be the dementia, even though we're at advanced stage 7, but see this trajectory of going into the hospital with a UTI or with kidney failure, or your heart percent fraction ejection is 10%. Those are the things that are a threat to your life. So sometimes it's prognostication help. Sometimes it's just trajectory. A lot of it is expectant education. And then other times it's the empathy, and it's the telling the caregivers they're doing a good job. Sometimes it's saying, hey, have you thought about respite care for yourself, and giving that caregiver family member permission to take a break. And what I like to say is, look, if you burn yourself out now and don't take a break, when your dementia loved one really needs you and you're crispy and cooked, you won't be able to step in and be your best. So if the storm is kind of calm right now, you need to get that respite. Don't feel guilty about it. You need to be the best version of yourself when there's stuff that you're going to step in. So that usually gives them some sort of permission. They get to blame me and say, well, the doctor told me I need to take a break. And that's okay. But some people become very overwhelmed and short-sighted in terms of putting the oxygen mask on themselves and just always putting the oxygen mask on the patient, which is the patient with dementia. It's easy for me as a person of privilege to say that because I don't take care of anybody with dementia, but the sentiment is that you have to find areas where you can take a break, whether it's 30 minutes, whether it's an hour, whether some people it's a week. They actually put the patient in respite. They go to Disney with their family. Their life has to go on, because if you're a stable dementia with nothing else going on, dementia is slow. It's more painful for the people watching than it is for the person experiencing it. So you can't absorb the 10 years and just be watchfully waiting for something to happen, especially if there's nothing else going on. So you're going to have to take a break. Life has to go on. You have to go to graduation. You have to travel. You still have to do stuff.
And I would add that the healthcare in itself is it's a complicated road to navigate. And so in addition to that, having a family member going through dementia or any other serious illness, it's just nice to have that extra support. And that's what palliative care is, and hospice. It's an extra layer of support. And it's an objective person who says, you know, you're working very hard. You are approaching burnout. And so it's just nice to have somebody who, again, like Dr. Tang said, you're doing a great job, but I'm concerned about you as well. And so it's not only support for the patient, but it's support for the caregivers and for the family. It's really important.
We're getting close to the end, but I have a really important question that somebody answered by typing an answer, so we didn't get to see what the response was. And the question was related to the fact that this individual is grieving and his wife is not gone. And so I would be interested to hear how you deal with that.
I did answer that question. Community Home Health and Hospice does have a grief support center located in Salmon Creek. That grief support center is open to the public. We provide services for youth, teens, and adults and families, including book clubs. There's a large support system in that grief center that is open to anybody who needs it. So you just feel free to contact the office and get in touch with grief support, and they'll be happy to let you know what they can do and a direction, or to come in and meet with us and talk to us about what's going on. And we can either find individual meetings or a group support meeting as well. We've had that support center in place, I believe, since 2017, I want to say, but it's a really, really great support system for the community. And that's open to anybody in our community that needs that support. Just reach out to us, give us a call. We'll be more than happy to help you and your family.
Yeah. And PeaceHealth has a similar grief center, bereavement over at off of MacArthur and Mill Plain.
We have a comment from one of our participants that says anticipatory grief is a huge problem for caregivers of people with dementia. And I also want to put a plug in, because it's a new program that Hope has started, a group called New Beginnings, which is for the individuals who have lost a loved one with dementia. But the other people that we invite to that are those who are undergoing the anticipatory grieving on a daily basis. An example of that is one of our participants whose wife has early onset when she was 53, and it's now 7 years later. And he is grieving daily. So that's what I was after a little bit. And I do know that both hospices offer help with anticipatory grieving. So that's what I had that I wanted people to be aware of. And the reason that we started that program is, interestingly enough, people who have lost a loved one from dementia have gone to some of our grief groups and then come back to our support groups and saying they don't get it. They don't understand. It's not the same. And yeah, just an interesting thing that you hear often enough that you know, gosh, it must be true. So I know that I have a final question that we wanted to ask each one of you. Assuming that I didn't lose it, what would each of you recommend or wish that people do to help themselves or their families related to end of life and people who have dementia? What jumps out at you?
I have two
Believe it or
things, actually.
not,
Oh, go ahead.
believe it or not, I have a slide. But I'll let Michael go and then I'll show you the slide.
You're muted,
Michael,
Mike.
you're muted.
There we go. The two things really is simply, and I've actually talked about them earlier, is don't wait until the last minute, get things started. Is really as early as possible. whether it be palliative care or hospice. Start looking into that as soon as possible. And then as caregivers, we were talking about caregiver burnout. It is okay to take care of yourself, and please do at any point in time that you can. And just a quick example, my mother has dementia, and my stepdad, has taken care of her. They're, in assisted living in a memory care unit. But with that being said, and there is support there, but with that being said, he feels that he needs to be there every day, twice a day. And as a family, we arranged a 4-day vacation out of town, fly out of town, and we'll take care of my mother. And he's been the sole caregiver for the last 2 years. He says he hasn't had a vacation in 2 years, and it wears on him, and you can see it. So just with that being said, take care of yourself.
My takeaway, or my giving to you takeaway, is how to communicate. This can cause a lot of frustration. I think this is a good summary. These are available on the internet of how to connect and interact. Part of the burnout and moral injury is that we try to reason. We might shame, we might lecture, we might say, I told you so. We might try to use logic. I, don't want to offer this anecdote to shame anything that happened in my family, but one of my family members had dementia, and one of our caregiver, family members kept on reasoning with her in terms of well, I told you that you already ate lunch, and today's date is blah, blah, blah. It's Thursday, not Monday. And this person came from the intent of, I miss my mom. I want her to reason with the logic that I have. So it came from a good intentional space, but the impact was just so burning, and it was just so morally defeating. And it was also causing some agitation on the side of the patient. And so that person, in the early stages, that person's still there, but in the later stages, that person isn't there anymore. That logic isn't there. So we don't want you to reason, shame, lecture, repeat things like, do you remember? I told you so, you can't, or demand things, or condescend or force. You want to stay on the side of diversion, distraction. Oh, you see a pink cat. Tell me more about the pink cat. It's not going to get you anywhere by saying there's no pink cat. I told you so. I've told you again, there's no such thing as a pink cat. Especially if the hallucination or delirium is pleasant, go with it. But if it is horrific, come see me. Let me give you some meds. Let me help medicate some of that suffering. But I think the space of how to communicate and how to reframe for yourself that this person is slowly walking away. This mind, this cognition is slowly waning away. It can mitigate some of that distress that you have, because you're still living in this world. The other person is in a different dimension. They're sometimes here, they're sometimes somewhere else. And so this is my slide to help you with your suffering as well as the patient. So that's my takeaway.
So there's a couple of things for myself. I did care for my grandmother through her dementia and Alzheimer's. So one really important thing to me in the beginning, before dementia really set in strongly, was to gather stories. Any stories that they can give you. So, sorry. Just get stories.
I think of anything, when you're the caregiver offering a hand to somebody with dementia, just don't forget to hold your hand out, because there are other people that can hold your hand as you're doing that. that it isn't just a one-way trip. Remember, you're helping give somebody a helping hand, but hold your hand out so somebody else can help you, because it's a long, hard journey, and it can be very taxing. The anticipatory grief is very real, because you're watching somebody walk slowly away from you. They're pulling away from you. That person you know or you knew is slowly fading away. They're starting to disappear from the person that they once were. So that's my words of advice.
We have a comment from a participant that says to get the individual with dementia to ID the people in the old photos, kind of to go along with the stories. So that's a great idea.
And that one's
Well,
actually a lot of fun too. I did that with my grandmother and it was a lot of fun.
it is fun, isn't it? So thank you, panelists, so much. This was incredibly helpful. I do have someone that is wondering if the particular slides that, I see that Dr. Tang saw that. If you wouldn't mind if you would send me copies of those slides, I will send them out to the folks that have registered for this. Thank you, thank you. And then I have one more thing for you. This has been a heavy topic, and so I want to share you something that is maybe a little more fun. I don't know why that's there. So on the 13th of December, this will be our 3rd year of doing Jingling with Hope. And Jake Beck is a music therapist here in town who we consider our friend. And we'll be having Jingling for Hope actually at CDM as well as on Zoom. And this time we will be at CDM because this is music, you know, we gotta be in person. So Joey will be our moderator, and Jake, who plays the guitar, and Kelly, who plays the harp, will be there. And it's all about music for Christmas. So everybody is invited. Please, I'll share this and let everybody know that we would love to have them come for Christmas celebrations. So thank you everyone so much, and have a wonderful holiday.
Thank you so much for having me. You have a wonderful holiday as well.
Thank you all.